Good afternoon, everyone. We're so grateful that you could spend some time with us today to learn about the 6 building blocks, a team-based approach to improving chronic pain management in primary care clinics. My name is Maria Clemestrud. I'm a Senior Improvement Advisor here at Comagin, and I'll be introducing our presentation today and then handing it off to Dr. Michael Parchman. Comagin's mission, together with our partners, we work to improve health and create a better healthcare system so that people and communities will flourish. Specifically with our opioid work, we promote safe prescribing practices, decrease opioid use, and improve behavioral health outcomes. We're grateful to recently have started our work with the 6 building blocks and to have Dr. Parchman with us for this work. He began his journey with the 6 building blocks in 2015 as co-developer, and he'll tell the story of this discovery. He now works with us as a subject matter expert and will be guiding a lot of the work that we do as practice facilitators in several areas through this contract with the Washington State Department of Health. Dr. Parchman is a senior investigator with Kaiser Permanente, Washington Health Research Institute. So please take it away.
Thank you so much, Maria. I just wanted to say, as a family physician, I'm well aware of the challenges and competing demands that go on in a primary care clinic setting. And many of us have been working on this issue of opioid prescribing for quite some time. Some of us put our efforts on hold during the pandemic and are now ready to think about what next in terms of continuing our work to improve how we manage opioid medications in people with long-term chronic pain. So why did we develop these 6 building blocks? Well, as you're aware, and it's probably not too surprising, the majority of opioid prescriptions actually come from primary care providers. If you look at the volume of opioids that go out the doors of our pharmacies. So, it's unlikely that we're going to address this epidemic without addressing the source of where these opioids are coming from. And the real point is to think about, it's not just the opioids that our patients use, it's the issue of the volume of opioids that come out of the pharmacies that sometimes get inadvertently diverted into our communities as well. So next slide. The point of this slide is that, hooray, we're making a lot of progress. Look at the decline in opioid prescribing since 2010, 2011. But also to say, we're still prescribing at 2 to 3 times the volume that we were back in the mid-1990s. In terms of the volume of prescription opioid use in our country. This comes from pharmacy and mail order pharmacy data, and this is where we are. And we still have ways to go to improve the volume of opioids that are going out the doors of our pharmacies. So next slide. And just a reminder, the issue is that these medications, the potential for harm from these medications may be greater than the potential for good in many, if not most cases of our patients who are on opioids long-term for chronic pain. And the risk, of course, is overdose. And it's not intentional overdose. Sometimes it's unintentional overdose. And that risk increases exponentially with dose, as demonstrated on this slide. Now, this data on this slide is from one study, but every study that's been done about the relationship between dose and risk of overdose has shown exactly the same exponential curve. Now, if you add someone who's also taking a benzodiazepine on top of this, you can shift this whole curve upward by several relative risk factors in terms of risk of overdose. So next slide. And this is old data. This data is from pre-pandemic. We now know this number is much higher. in terms of the number of Americans who die every day from an opioid overdose. And although the majority of overdoses today are due to fentanyl or heroin, street drugs, the issue is that prescription opioids are sometimes a gateway or a pathway to the use of those drugs. And so numbers of studies have pointed out that connection, that people start with using prescription opioids, sometimes opioids that were diverted off from someone's house, someone's medicine cabinet, and got into the street. And those prescription opioids are the pathway to use of these street drugs like fentanyl and heroin that lead to these overdoses. And this is an issue for us in terms of our communities that we live in. We want our communities to be healthy as well. So next slide. So where did the 6 building block program come from? So we knew there's this problem. We knew primary care clinics were struggling with this issue about managing opioid medications in patients with chronic pain. This was a totally separate project. We were out there visiting 30 primary care clinics as part of a different effort, a different project, to see how they delivered team-based care. And what we noticed is that 20 out of the 30 had made significant changes in how they were managing patients on long-term opioids. And there were similarities about what these 20 clinics were doing in terms of how they got there. It's not what they were doing in the moment. It was the journey or the path that they took to get to where they are now that led to the 6 building blocks program, because the 6 building blocks came out of our observations of these 20 clinics. So next slide. So these are lessons learned from primary care clinics like you. These were what these primary care clinics did. They developed a consensus in their clinic that this is an area that they needed to improve. Leadership supported change in this area. They tackled thinking about what is our consensus about how we want to prescribe and manage opioid medications. What is our consensus about how we want to manage our patients with chronic pain that is consistent with the evidence? So they began revising their policies with everybody's input in the clinic, revising their patient agreements, so those contracts or those agreements with patients about, yes, we'll prescribe this medication and this is our responsibility to keep you safe. This is your responsibility as a patient, so that we make sure you're safe with using these medications, and then creating workflows that helped implement those policies and agreements. Many of them had not been able to even track who was on opioids long-term in their clinic. And so they had to develop some systems to be able to even identify who are our patients, because we don't want them falling between the cracks and not getting the care that they deserve. So they began developing tracking and monitoring systems. They began thinking about the visits themselves and preparing for them and saying, what needs to happen at the next visit to make sure this patient is safe? And who is responsible for that? And how do we build that into our workflow? And what information do we need to bring into the visit that is important for the patient to know? For example, is this a patient that we need to talk about getting a naloxone prescription? Well, maybe they should bring a family member with them so we can talk about how to use naloxone in case there is an unintentional overdose. They began talking about patients with complex needs. No patients with chronic pain oftentimes have co-occurring conditions, especially mental behavioral health conditions that require additional resources, that require additional care. And how are we going to get them that care? And finally, they began thinking about, if we're going to make these efforts to make these changes in our clinics, how are we going to know they're making a difference? How are we going to monitor or measure what we're trying to change to see if it's improving things? Because otherwise, it's very disappointing to make all these, go to all this effort, make these changes, and then say, we're not sure it really made a difference because we really didn't measure it. We don't know how things really improved or if they improved. So how do you measure success? So next slide. What we observed when we went out to study this program, where we actually enrolled clinics in a study to see if this 6 building blocks program worked, is that they had 3 stages of work that they went through. This prepare and launch phase, which took them several months. This wasn't an easy lift. This was not an easy lift for them. This prepare and launch stage laid the groundwork for making sure that they could make these changes. The design and implement phase, where they actually started implementing these changes and then figuring out how they were going to sustain the changes over time. So it gives you a sense of the type of work that they did. Importantly, this initial clinic-wide kickoff effort, where they actually sat down and said, now how are we going to do this together as a team, was really important to kicking off this area. And this expert guidance from a practice coach or a facilitator external to the clinic made a huge difference in them being able to actually lever intrinsic motivation within their own clinic and staff to making these changes, and having these shared learning calls where they could visit with other clinics about how did you do that? What did you do? Can you share that with us? What does your patient agreement look like? How can we learn from that? So this was a really fun study. Next slide. I think this is the most gratifying outcome from that study, is that one of the medical directors that implemented the program told us this, that everyone in their clinic felt like their patients were safer. They felt like there was less disruption in their practice after making these changes in their clinic. Next slide. And, you know, there was also significant improvement in the number of their patients who continued on long-term opioids for chronic pain. And of those who continued, they saw a steady, slow decline in the proportion of patients that are on higher dose opioids as a result of implementing these changes in their clinic. So they felt like they were delivering care that was more evidence-based. They actually were surprised that they didn't get as much pushback from patients as they thought they would when implementing these changes. And many patients were grateful that these issues are being discussed with them. And some patients actually self-tapered off their opioids with very little support from the clinicians and staff in the clinics. So next slide. And so this increased confidence and comfort in caring for patients with chronic pain was one of the things that we documented as a result of this study. There was increased collaboration and teamwork, but they reported their stress levels were down. You know, we could think about burnout and stress in primary care today, especially coming out of the pandemic. What can we do to reduce stress in primary care? How can we reduce burnout in our providers and patients? Well, this may be one way to think about it. How do we improve the work life of the staff and the clinicians in primary care? And think about people who have chronic pain who are on long-term opioids, and how can we support our clinicians and patients, clinicians and staff in doing this work? And then the staff and the clinicians said, you know, actually our relationship with our chronic pain patients improved when we did this work. So next slide. After the study was over, the 6 building blocks team really provided several years worth of direct coaching to practices across Washington state with support from the Washington Department of Health to help primary care clinics implement this program. And we've had considerable experience and quite a bit of success with clinics diving in and saying, here's where we need help and here's where we can improve. We've also trained quality improvement staff who work in these clinics to actually do the coaching. We've led national webinars about how to make this work with support from your state departments of health. And finally, I can't not mention the fact that clinics that do this work became acutely aware of the fact that they probably had patients with an opioid use disorder that were not previously recognized. And they began thinking about, what are we going to do for these patients with this condition? And how do we get them the care they need? And out of that came an experience where we developed and fostered a collaborative learning experience for primary care clinics about how do you integrate medication for opioid use disorder into a primary care clinic setting. And that was one of the most satisfying pieces of work that we've done coming out of this. So next slide. There are a number of other programs nationally that have adopted the 6 building blocks and actually reference it in their materials and their resources. These are just a few of them. So I think there's some evidence. I think there's some recognition nationally that if we're going to make improvements in how we manage patients with chronic pain, this is one area we need to work in, and making the changes that are described in these 6 building blocks is a structured, evidence-based way to change the systems in a clinic to improve care and support clinicians and staff in doing that. So, as I said before, many of us went into the pandemic having already done some significant work on this that got put on hold. Many of us are experiencing patients who've lost their primary care provider, who's either retired or there's been turnover, and we're inheriting patients who are on a legacy prescription of opioids in our clinics and trying to figure out what to do with them. Or we've had clinicians or providers who've left, and we have to redistribute patients who are on long-term opioids across our teams. And we find we need a way to support them. And this is maybe one program or one way you can do that. So next slide. Maria, I'm going to pass it back over to you.
Great. Thank you so much for sharing the story. Thanks to all of you for spending time with us. We will be recruiting 12 primary care practices for an 8-month project. And if you think you're interested, if you think your clinic could benefit, if you just want to have a conversation with us about where to start or to learn more, please email 6bb@comagine.org and we can schedule a brief call or communicate through email. We're also recruiting for a second cohort of an MOUD Learning Collaborative, and there'll be 6 primary care practices in Washington State participating in that. So you could use the same email if you'd like to share your interest or your question, or if you just want to connect with us. We would love to hear from you. So thanks for being with us, and we hope to see you again soon.